Thank you very much for the organizer for this kind invitation. This is the outline. We'll go through a brief introduction and then through the systematic review of the epileptogenic zone for abdominal auras, and then we'll come up with a conclusion. Just giving some historical remarks. Dr. Tissot, who developed most of his career in Lausanne, he described a case with nausea and emetic seizures related to a condition which was not affecting the GI tract, and he suspected it to be epileptic in nature. Later on, it was Herpin who described patients with paroxysmal stomach discomfort, and he suspected to be epileptic as it was frequently followed by generalized motor seizures. And he was the first one that described how occasionally the sensation would travel up towards the neck. The definition of abdominal aura, so epigastric aura is described under gastrointestinal ictal phenomena by Beninsky and colleagues in 2022. This is an abdominal abnormal feeling in the epigastric region produced by an epileptiform discharge. This is a pure subjective feeling. Therefore, patients with motor seizures of the abdominal muscle should not be discussed as having abdominal aura, and similarly should be debated about painful or paresthetic somatosensory auras localized to the abdominal region. So considering most reports of paresthetic and painful somatosensory auras localized to the abdominal region, they do evolve into clonic seizures of the abdominal musculature. So it was described in detail by Van Buren in 1963. The nature of the sensation was non-specific on the majority of the patients, and the location was most frequently midline and epigastric. He described 100 patients. The sensation was static in most of the patients and would be migrating upwards and midline, mostly up to the chest and the throat, and occasionally all the way up to the face and head. It's most frequently seen in patients with temporal lobe epilepsy, most frequently mesial temporal lobe epilepsy than neocortical temporal lobe epilepsy, and patients with temporal lobe epilepsy and abdominal auras may have a better postoperative seizure outcome as compared with patients without auras. It was reported to lateralize to non-dominant hemisphere in earlier reports, but this has not been reproduced in subsequent studies. Abdominal sensations have been elicited by direct cortical stimulation in the insula very reliably, but also by Penfield and Rasmussen in the precentral operculum, and there are also some series of producing abdominal sensation stimulating the mesial temporal lobe structures, but as my understanding it is, during the provocation of seizures. So we did perform a systematic review of focal epilepsy to summarize the anatomoclinical correlation for abdominal auras. The results were reported according to PRISMA statement. The main search was done in PubMed. The key words that we use are abdominal auras, epigastric aura, viscerosensory aura, epigastric rising sensation combined with surgical evaluation, epilepsy surgery, and so on. The criteria for selection of articles was high or very high confidence in the documented epileptogenic zone for patients with abdominal auras. We did not include less than 5 patients with documented abdominal auras initially, but then we made an exception with 3 studies that were documented insular, frontal, and posterior cingulate epileptogenic zones that had a low number of patients with auras. So this is what the methodology we've been using to define how reliable the reference is. So this has been divided in very high, moderate, and low. So as you can see, very high are patients that have Engel class 1A, only 1A. High confidence would be a delineated focal lesion that is suspected to be the epileptogenic zone, a delineated epileptogenic zone or seizure onset zone, according to all available invasive recording, or having an Engel class 1, but not specified to be 1A. Moderate would be MRI signs, for example, of hippocampal sclerosis or atrophy, suspected to be at least part of the epileptogenic zone, and then low confidence would be the rest. So the MRI would be normal or poorly delineated, like having extensive abnormalities or multifocal abnormalities, and then having an Engel class 2 to 4, or having had surgical failure. So with the search that we did, we got 170 citations, and then the number of abstracts were reviewed were 149, which were available, and we had a significant number of unrelated topics to the study and duplicates. And then we also excluded, as I said, case reports and many of the reviews. The number of articles reviewed, there were no systematic reviews, but literature reviews we excluded. We had a number of article reviews that were 34, and then unfortunately there was a lot of unclear data in patients with abdominal auras, and I will explain to you later on in the limitations why. And then there was a significant number of patients that have low confidence in the epileptogenic zone. Therefore, we stick so far to a number of selected articles that are 14, with a number of patients included of 392. So these are some of the studies, all of the studies, the 14 that we have included so far. So on the left, you can see you have the study number, and then you have the number of patients with abdominal auras, percentage of MRI positive, percentage of SEEG implantation in patients with abdominal auras, the percentage of patients that were operated, and then the percentage of patients that has class 1. And then based on this information, we determine with the guidelines that I show you, the confidence in the epileptogenic zone. So the first paper is the one by Henkel et al. They included consecutive patients who underwent pre-surgical evaluation. And as you can see, the degree of confidence is based on imaging mostly. And as you can see, we broke their study in 3 arms. So one, the temporal arm, the frontal lobe arm, and then a posterior parieto-occipital arm. And these are the different, the confidence was mostly high, but again, there was a number of patients with low confidence. Then we have the publication from Asadi, Poya et al. They studied temporal lobe epilepsy with hippocampal sclerosis who underwent anterior temporal lobectomy, and they wanted to investigate whether auras can predict a surgical outcome. And they did find that patients with abdominal auras did better postoperatively compared to patients without auras. Then the paper of Sare in 2020, they studied consecutive patients with mesial temporal lobe epilepsy who underwent amygdalo-hypocampectomy. And they studied the relationship of the auras and the surgical outcome also. Then you have the paper number 4, Maisuliana, in which they studied consecutive patients with neocortical epilepsy. And for these patients, they did a lesionectomy, and they preserved mesial structures. And then they matched these patients with patients who had temporal lobe epilepsy that were mesial, and they were seizure-free with amygdalo-hypocampectomy. And they wanted to learn, the main semiological difference between. Then Abarrategui, which is the paper Never Ending Story from the Milano group. They studied seizure semiology in patients with temporal lobe epilepsy, and they did compare patients that are seizure-free with patients that are not seizure-free, and they essentially wanted to identify red flags that could predict eventually that a patient, semiological red flags that will predict that a patient is not going to do well. And what we did here is we just took the arm of seizure-free patients for the purpose of our study. And as you can see, 19 patients, for example, that had abdominal auras out of 46 patients who were Engel 1A class. Then the paper by Wades, they included patients with multiple auras to state its significance, and they found multiple auras that are related to non-dominant epilepsy. Then you have ERCOT paper that included consecutive patients that had undergone anterior temporal lobectomy. Yu et al. Paper, they identified the prognostic value of auras in temporal lobe epilepsy after SEEG and anterior temporal lobectomy. And they had an aura-positive arm and an aura-negative arm. Thank you. Then Dantas and colleagues, they explore the difference in patients with mesial temporal lobe epilepsy and neocortical epilepsy. And Fogarasi and colleagues, they studied autonomic symptoms in patients undergoing presurgical evaluation. They had a temporal group and an extratemporal group. The extratemporal group only had one patient with abdominal auras, and mostly were, most of the auras were within the temporal group. Then finally, we have Hill-Nagel paper and Riesinger. They studied the differences in patients with mesial temporal lobe epilepsy and extramesial temporal lobe epilepsy. Jing and colleagues in 2021, they actually studied auras in frontal lobe epilepsy. So all the patients that they knew they had frontal lobe epilepsy because they were seizure-free. They didn't specify. But all of the patients they included that had frontal lobe epilepsy and were seizure-free, all of them had to have auras. So really the sample, but only 4 out of 54 patients had abdominal auras. So even though they included only auras, really the abdominal auras were not very high on the list. Then you have Pelliccia et al., also from the Milano group. And in this paper, they studied the whole cingulate epilepsy from the most anterior aspect to the posterior aspect. And from these 57 patients, they only found 3 with abdominal aura, and the 3 of them were among 7 patients that had the epileptogenic zone located in the posterior cingulate. And again, these patients were all 100% seizure-free. Then we have Peltola in 2020, in which they studied insular lobe epilepsy that underwent stereotactic EEG, and they had a seizure onset zone that was confined to the insula. So this is the summary of the selected patients. Here you have, again, the variables, number of patients with abdominal aura, the MRI positive, percentage of patients with SEEG, percentage of patients that were operated, how many of them, or the percentage that had class 1 in more than 1 year, and then what was the high or very high confidence in the epileptogenic zone. So the minimum of patients was the Insula paper. We had 2, and the maximum 117 patients with a median of 12 and a total of 392. A percentage of MRI positive, we had a total of 81%. SEEG, we had a significant number of patients in which this data was unclear in most of the paper. So we went down to 6%. And then percentage of patients that were operated, 41%. And then the class Engel was 38% because we had this large, group from Henkel who had not had surgery. But overall, we felt that, in the summary, there is a very high confidence in the epileptogenic zone among the 14 articles. This is the brain region, so all of these papers applied mostly to the temporal lobe, and then some of them to the insular cortex, frontal, and posterior cingulate. All of the symptoms, abdominal auras, occurred at the onset, and the overall grade, how comfortable we felt that these areas were actually participating as the epileptogenic zone was high. And this is just to show you how the percentage of patients presented with abdominal aura were distributed. So essentially more than 80% of all of the patients had temporal lobe epilepsy, and then a minority of patients had other epileptogenic zones like frontal, posterior cingulate, or insular epilepsy. This is just to show you only the patients that had very high confidence of mesial temporal lobe epilepsy and very high confidence of neocortical epilepsy. And you can see the percentage of patients with abdominal auras in mesial temporal lobe epilepsy, as other literature has reported before, really supports that. So abdominal auras are most likely to be, if the patient has most likely temporal lobe epilepsy, most likely will be mesial temporal more than neocortical. And then this is, again, things looked, the other way around. So essentially, these are percentage of patients with temporal lobe epilepsy that had epileptic aura, so abdominal aura. So essentially, we took among all of these papers, epileptogenic zone that were very likely, or like they have like a very high or high confidence, and we calculated how many patients within those had abdominal auras. So among all patients with temporal lobe epilepsy, 28% of these had abdominal auras. And then among the insular epilepsy, again, the number was very low. 18% had abdominal auras, and then frontal lobe epilepsy, 7%, and cingulate, 5%. So our conclusion so far is that there is a very high evidence that abdominal aura is associated with temporal lobe epilepsy, that abdominal auras are more frequent in mesial than neocortical epilepsy, that there is a high confidence that abdominal auras are also associated to frontal, insular, and posterior cingulate epilepsies, even though the patients are few. The actual seizure freedom give us the reassurance of this. And, these epilepsies are very infrequent compared to temporal lobe epilepsy, and therefore is less likely to be encountered. And the number of patients with frontal lobe epilepsy detected in this review is very low, and not enough to really delineate which area of the frontal lobe is most likely to be related to abdominal auras. So that was a limitation. Then something that we found very problematic is that most studies lack a clear definition of abdominal aura and also do not specify well the nature of the symptomatology. And many high-quality studies are focused in investigating different types of epilepsies rather than a particular symptomatology. And this results in missing detailed information for each individual patient who documented abdominal aura. So there is some general idea of percentage of patients seizure-free or that underwent SEEG, but it's really not stated for our patients that we are interested in. And then we did not include cortical stimulation papers. I think that a separate grading system for stimulation results could be discussed. And that's what I have so far. Thank you very much.